I'd like to go ahead and get started with Dr. Parker, and we'll start with sort of the comments and perspectives from each of their particular areas of focus related to data standards and quality.
Great. I'm Dave Parker. I'm a family physician, clinical informaticist that works with the Department of Defense and the VA primarily in the areas of interoperability. There's lots of things you can talk about with standards and quality and interoperability, lots of buzzwords that you can play. I want to bring back a little bit to just to try to get a core point across. Interoperability is often defined many ways, but a simple definition is exchange of information and use of that information. And the exchange of the information is the necessary part of the equation. It takes that to occur, but the important part of the equation is to actually use it and how you use it and making it useful. One of our challenges in the federal space is that there's so often legislatively I see Terry smiling at me right now. She knows where I'm going. Relatively arbitrary legislation for which we work so very hard just to become compliant, if you will. And that's not only in our space, but that's certainly true. And often you're working very hard to maximize some relatively arbitrary metric, perhaps, and in a similar sort of sense. I advocate very much that the exchange that you're working for must be for a purpose to be relevant. And so right now, the key purpose that we've got, the key use of our exchanges that we've got is a very important step. It's trying to come up with a comprehensive, hopefully accurate record that a clinician or a patient can see. Just let me see the information. That's sort of where our focus has been, and that's actually a really important start to work on that. More recently, in our last couple of years, there's been a very strong push for semantic interoperability, making sure that the meaning is understood, and that has a lot to do with codes and terminologies and the standards around those, mapping to them and all kinds of things. And one of the struggles that we have faced, in my opinion, is that we have, again, fallen into the trap where we spend so much time on just kind of being compliant with, let's exchange it and something good will happen. You know, if you build it, they will come only really applies if you build something people want. And so, creating an exchange for exchange's sake is a trap that we too often fall into. So the clear point for me is that we should always remember to focus on the use. The means and the standards and all of that are just the means by which you do that. We need to really focus on the use. How are you using that data? Frankly, lots of uses that we have can be adequately handled by a PDF of a piece of paper. Not all of them, but if your use at the time is, I need to know the MRI on this patient in front of me so that I know the right treatment and don't have to duplicate a test that could be harmful. That's all you need sometimes. But we very much are spending a lot of time moving beyond that basic step. And that's okay. We're learning a lot. We're learning a lot about our data, good, bad, and indifferent. We are learning a lot about what the standards mean and the status of the standards and how you go about doing the more sophisticated kinds of things. We haven't really figured out how to use that information very well yet, but we are starting there. And so, I just want to make that point that we focus on the use. I think the opportunities for us are several for easy, quick wins. I'm a clinician. I like to dream about the day when everything happens magically for me. And but frankly, there's some very good first steps that some of this extra work that we are doing for semantic interoperability and the coding and mapping and all that can be put to really good use. you can use the standards to be useful. Well, let me step back a second. Even just plain exchange, the most important thing you could do is make sure that whatever it is you exchange, it comes into the workflow where it is needed. You're not going making the physician take extra steps. They're burdened already. They take extra steps to make any use, because they just won't. It just doesn't happen. So bring it in directly into the workflow is one of the most important things you can do, in an accurate and timely manner, by the way. Once you get past that, some simple things that you can do is help. If you understand what the data is, you can make it more the usability better. You can organize it better. You can filter the junk out, and trust me, there's plenty of junk that you have to deal with. And then you start doing those sorts of things, and then people will come to what you built, because that is helping them do their job better. And that's both for clinicians and for patients. The noise is plenty for both. And so I'm going to leave it at that.
Great. Well, good morning, everybody. And primarily on ONC's relationship with states that are doing delivery and payment system reform. And I mentioned during the first panel, the first time that I met Dr. Cullen, so I'm going to go ahead and say this again since you're here. You can tell people whether I'm misrepresenting. But so we were on a phone call with Dr. Mostashari, the previous national coordinator, and Todd Park. And I was at the time working in the state of Vermont as the state coordinator, HIT coordinator, and deputy commissioner of health reform. And I was agitating about the need for better alignment of identity management at the state and federal level. And at one point, Farzad said, I don't understand, like, why is this such a problem? And Terry spoke up and said, it's us, Farzad. It's the feds. We created this problem. And well, I took heart in imagining that I heard that, because I thought that, well, if the feds created the problem, then maybe the feds could help solve the problem. And I think that that's true, although having now worked myself at the federal level for a little while, I would say that the feds are a necessary but not fully sufficient part of the solution. And that's why I think that this gathering here is so important, because really the feds, industry, providers, and states working together are really the solution to advancing this, because it is such an enormous project that we have to work together. So as I said, I work with states on their delivery and payment system reform, and a lot of what states experience is sort of the output or end point of a lot of federal systems. And for so much of what they're trying to do, because they're really looking not just at total cost of care, but ultimately at total cost of health, because from a state perspective, the total population is the denominator. You really want to be able to get as much information as possible, and that at the moment, interoperability across human services and healthcare systems is challenging. And so I think that the National Information Exchange model, the NEEM model that was brought up earlier by Shemendra, is an incredibly important asset that we need to leverage and think about how we crosswalk that with HL7, because the world of delivery and payment system reform really is about comprehensively looking at individuals, not just the small percentage of the time when they're in the healthcare system itself, but their total lives wherever they are. And really a lot of that, particularly with some of our highest cost, highest need patients, is when they're touched by human services and social workers at community-based organizations, et cetera. So there's a real paradigm issue here, because HL7 and NEEM were created for similar reasons in that they're both data exchange standards, but at really different points in time for different reasons. So HL7 was all about communication internally within enterprises, versus NEEM being from the outset being about national communication across boundaries. And so thinking about doing system-to-system, cross-boundary, cross-enterprise communication is incredibly important, and I would look to this group as a potential, significant champion and enabler of moving this forward, because I think that sometimes within the healthcare space, folks who are working in health IT sort of drag along the burdens of the incredible complexity, and it is complex data, absolutely. It is more complex than lots of other data, but that kind of worldview and perspective can tend to lead to a little bit of specialness in perspective, and so there's been a kind of historical resistance and pushback between the kind of crosswalk that probably really needs to happen between NEAM and HL7. And so starting with a really small, probably demographically focused data translation set could be incredibly beneficial and could help advance where we all want to go. So I'll leave it at that.
Wise choice coming to the second version of the panel. Expecting that our presentations would be crisper, the punchlines funnier, and that we just have a better general overall approach here. So my name is Steve Posnack. I'm from the Office of the National Coordinator for Health Information Technology. If you call my voicemail, you should actually hear the formal ending before I ask you to leave a message. So I am in a new role now as the director of our Office of Standards and Technology and responsible for a number of different areas, some of which include our testing and standards implementation activities, initiatives and coordination relevant to the Standards and Interoperability Framework, and the HIT Standards Committee, which is a federal advisory committee that makes recommendations to my office, the management support for the federal health architecture, as well as ONC's Health IT certification program. And I'm trying to think of the other things that I should mention to leave more time this time, I think, around for discussion with everyone. I told a story, which I guess I'll subject my panelists to again, of my experience in the healthcare environment. So I have 2 young children, which allows me to intersect with the healthcare system a lot more than I used to be, being one of the, I'd like to think I'm still an invincible. And so I have a 4-year-old and a 1-year-old, and the 4-year-old had to go to the urgent care, and the recent experience is that as I went in, and I'll tell this a little bit shorter, as I mentioned, the punchline will be crisper. I went in, he came in with 1 name and he left with 3. So a lab test had his name spelt wrong in one way, the portal email that I got had his name spelt wrong in a different way, and then the bill that I signed when I was leaving had his name correct, obviously. So we can still see where our system is kind of designed around the payment process. The other one, which I'll add in now as I remember some of my other anecdotes, so we live in a world where there are standards and there is interoperability, and I'll tell my story first and then go through my list. And so Joe has a list. I hope I won't steal any of his thunder here because my list is different than his list. Where I have e-prescribing, right? So those of you that know, lots of e-prescriptions nowadays, over 1 billion, I think, the last year. That's probably one of the most successful transitions from paper to electronic that we've seen in this industry. And now when I go to the pediatrician, I'm like, yes, e-prescribe, please. My pharmacy is the one you have in your system. But the process and the people hasn't caught up to the technology. So I literally have to call my CVS and say, I'm coming to pick up this prescription, and they electronically prescribe you. Otherwise, they won't fill it because they don't know if I'm coming. And it boggles my mind because now I joke that I've driven faster than the e-prescription, which doesn't make any sense. And I equally compare that to an alternative experience, which is another anecdote that I'll leave here. So I used to live in a condo in Arlington, and the way in which it was structured was we had this little pool patio, but we also had a grill. So I love to grill. But I could only grill with a lifeguard because the pool was only open when a lifeguard was there. And what made matters worse is that I was on the condo board. So I complained about this every time to my colleagues, but there was nothing I could do because we couldn't move the grill anywhere else. So these are the similar kind of experiences that we have in healthcare, where it's like the standards are there are rules there, you're coding the data appropriately, but there's still people and processes that are involved in the world in which we live. And so, back on track here, we're at a point now where there's a lot of adoption. A lot of providers have electronic systems. They may not be the first system and the only system that they stay on, but they're experiencing now an electronic environment in which the data quality and standards issues that we have are under the spotlight. And I think we're seeing a lot of issues creep up and improvements that we can make. And that's a feedback loop that we've had for the first time now that we have enough adoption to really give us a better signal to noise ratio in terms of what the issues are. And so I'll kind of leave it to that and turn it over.
Great. Hi, good morning. Mark Brown, independent consultant, formerly a senior information security officer in HHS. As I said earlier, I'm re-engaging myself into the HHS related topics, and particularly with health IT. And as I was preparing for this conference, I was blown away, as I said in the earlier panel, about the sheer amount of data that we're dealing with here. And for a cyber person, security person, that can stretch our capabilities, our normal processes of securing data when we consider the sheer volume of it. There are foundational processes that we take, of course, but what I am finding is that the traditional ways of protecting, normally we define boundaries around systems and determine the elements and nodes of a network to secure. But as we now move into this widely diverse world of partners and health information exchanges and customers and clients and those who need to input and receive and manipulate data, it is stretching the normal boundaries of cybersecurity and what we normally do. For one of my other clients, we're increasingly looking at the securing of the information, moving from ComSec to InfoSec, and seeing how we can provide security at the data level. One solution that we're looking at is where data is cryptographically split. And with each data share, data store, there's intelligent information so that you can know not only the origin of the data, but who should have access on a role-based level, and those who need to access data, the interface then reveals information that's relevant to their role, and that only. They don't know what they don't see. And so there are ways that we're moving to a more information data-based secure process. We also recognize that there is a need for us to be more agile in how we are responding to the requirements of health IT. There are partnerships that need to be formed at the policy level. We need to understand the various uses, even when we look at something like consent, where before a significant amount of energy was spent in trying to determine exactly what consent meant. We see now that we may need to not be so stringently in defining the exact definition of consent, but also looking at the possible uses of data and making sure that policies accommodate the possibilities. And then let our security and privacy processes allow for those things to be utilized. There are, at the system development level, where security should be built, we also need to consider that with all that health IT is offering and extending with all the players in the game, that the system is built in a way with security features that allow for these roles to be accurately parsed and access given. And so we are, as I orient myself more with where health IT is going, and I consider as I said earlier, the traditional security processes that we would employ, we're recognizing the need to be more flexible, to not compromise or soften the security requirements, but making sure that we're clear on exactly where things are going so that we could move in a way, create the security parameters and protections that accommodate the direction of health IT. It is important for us to engage in forums like this, to be more aware of what the requirements, what the evolution of health IT requirements are. I believe in the past, security and privacy requirements stood as immovable brick walls by which you had to work around, not around. I'm doing again the same mistake that Mr. Paul made, that you had to work within. We now are seeing that we may have to reconsider how we not only define but employ some security requirements so that we can accommodate what needs to be done in this area. So the dialogue is good. Forums like this are critical. And my hope is that we can continue to engage as we move forward so that we can have an effective solution to what's needed.
Well, I'm Joe Francis. My title there is wrong. We change our titles periodically in VA, so I'm actually now called Director of Clinical Analytics and Reporting. And I'm not an informatics guy. I'm not an interoperability guy. I'm what Terry described earlier as the operability person, because I get to depend on the work that people like Terry and Hunt and Steve and David do to have data that we can analyze to understand our health system performance and to make suggestions for performance improvement. And so let me tell you my 7 points, which kind of encapsulate my world. The first is that data really speaks for itself. I'm not quite sure how I do analysis. I imagine it's, over time you learn how to connect the dots. The most important dots to connect are the dots for a specific patient over time. And if you talk about population health and patient outcomes, most of what happens to patients happens over decades, not days or weeks. The management of diabetes, the management of blood pressure, the management of PTSD, those are outcomes that have to be tracked over the long haul. And so, simple things like identity management, consistency of information, formatting. How do I work in both an 8-track tape world and a CD or iPod world with data systems that are constantly being updated? And I have no idea how this gets done in the private sector, where health plans and physicians change with every open season. Currently, I think only the IHS, DOD, and VA have a health system that can actually do the longitudinal dot connecting to improve population health. My second principle is that remember that data is 2 steps removed from reality. You have an interaction between a clinician and a patient. Make no mistake, most of data reporting is not automated. Some poor bloke, often a nurse or a doctor or maybe a scribe if you're in a rich practice, is typing that information in. Errors are being introduced. Sometimes the patient agenda is not being reflected. And then we have to dive in there with very imperfect extraction routines, whether it's through standardized structured data or natural language programming, to kind of extract computable information from that. And there are many places where the signal gets distorted. Principle number 3, related to this earlier one, our providers are overwhelmed. And not only is it difficult to ask them to input more information, you have to respect the fact that sometimes they're in a war zone. I think any emergency room, any inpatient floor is a war zone. And if the system gets in the way, they will find workarounds and shortcuts. And by the way, if we try to give them all the information we think they need for decision making, the paradox is information overload will probably increase the likelihood of their making mistakes. These are well documented by people like Clem McDonald and Hardeep Singh in our system, and are true for every electronic health record that's out there. Principle number 4, we have blind spots. Most of our veterans have other sources of insurance coverage. The new legislation, the Veterans Choice Act, has us now paying for care in the private sector if we can't see veterans in 30 days or if they have to drive more than 40 miles. That private sector is not interoperable with us. We will be happy to get a faxed note that we can scan into our system, but that's not something that I can use for tracking and ensuring quality on an automated electronic basis. Number 5, data analysis and performance measurement is a liberal art. It's really about the psychology of motivation. How do you give information and numbers to clinicians so they change their behavior, or increasingly to patients? You know, think about Fitbit. It's not the numbers that matter, it's whether they take more steps day after day and improve their health. And so, rather than getting, fancier on the data, think about how do we package the information to motivate and change behavior on both the provider and the patient side. There are better ways of doing this. This is number 6, but we only have glimpses of this. Paper that fascinated me last year in the New England Journal by John Berkmeyer and his colleagues at the University of Michigan. We've been trying for years to see a correlation between surgical care process measures, SCIP measures, raise your hands if you're familiar with Joint Commission, and surgical outcomes, and there ain't none. But if you can put a camera in the OR and actually watch how the stitches are being placed and have a blinded panel of surgeons rate how careful the stitches are being placed and whether there's any tremor, it turns out that correlates very nicely with surgical outcomes and complications in high-risk procedures like bariatrics. I mean, this is the equivalent of a black box in an airplane. And that probably needs to become increasingly the type of quality feedback that we can build into our systems, and no one is basically doing that now. Our computerized records are basically word processors and not capturing in real time what's going on. Lastly, just a point, my frustration is no one cares about infrastructure until the bridge collapses. I work with really smart, dedicated people like Mike Lincoln, Keith Campbell, Steve Brown. Some of you have heard of them. It is really hard for Terry and that office to amass a business case to say, oh, invest in S&I, when we have so many short-term needs, like a new scheduling package. It's kind of hard to say no on that one after what's happened to VA recently. But that's going to displace or postpone some of the more fundamental work that really needs to be done. And maybe if there is a ask for industry, is to help educate our appropriators and our authorizers and our senior federal officials that this too is important and needs to be supported and needs to be one of the first things that we pay for rather than the afterthought after we do some of the other things down the line. Thank you.
Hi, I'm Marianne Rocky from the DoD Healthcare Management Systems, the PEO, Program Executive Office. I was asked by someone, what's a Program Executive Office? So thought I'd start with a little bit of that. In DoD acquisition parlance, there's a program manager, and that program manager reports to a PEO. And then the PEO usually reports to either a service acquisition executive or a component acquisition executive, and then reports to a milestone decision authority. And that's kind of, for acquisitions in a big department like Department of Defense, that kind of cuts through all the bureaucracy, where our PMs in the past were, I have to brief like 40 million people before I can even try to get an answer. Now that it's, you go to the PEO, you go to the SAE or CAE, and then you go to the milestone decision authority, decision made. In our case, it was cut even shorter because our PEO reports directly to the undersecretary, who is the milestone decision authority. So the PM only has 2 steps to get a decision, and that was done on purpose. The programs that we have under our PEO, modernization of the electronic health record is one of them. Interoperability called DMIX, that program office is another one. And then we share responsibility for the interagency program office, the IPO, with the VA in our oversight of that organization. So just, I'm going to talk mainly about interoperability, but a little bit, many of you may know about the other two, but I'll just talk a little bit about those. On our modernization program, we actually have an RFP on the street on FedBizOps. Proposals due October 9th, if you guys got to get your proposals in. And that is the modernization of our EHR. When you think about our history, 26 years ago, we were in the midst of deploying something called CHCS. 13 years ago, we were in the midst of deploying something called Alta. And where were we 13 years ago with health IT in general and with EHRs? The adoption rate for EHRs when we were deploying Alta just 13 years ago was less than 5%, more like 2 to 3%. And as Karen DeSalvo talked about this morning, adoption rates for EHR, one of those success stories of meaningful use. I think everybody was kind of on the edge, and that just kind of helped push it. Meaningful use adoption rates 90% in hospitals and 75% in other places. Very high. We have hundreds of certified health IT products out there. So for this modernization effort, to replace our legacy electronic health record capabilities, we are looking to the private sector in an off-the-shelf solution. So that's one of our programs that we're working on. IPO was rechartered this past December. They're focused on interoperability, working with ONC, HL7, and all the different health standards organizations to advocate for DoD and VA needs in health data interoperability standards. They also provide us with a review of our efforts in interoperability in DoD and VA and how we're doing. They send a annual report card to Congress on interoperability, and they send quarterly reports to Congress as well on how well DoD and VA are doing on interoperability. And then the third office called DMIX, DoD Medical Information Exchange. What we're doing in there is the interoperability piece. And what we did just in January is we took, interoperability was kind of spread out in various program offices. So we took the interoperability and we put it all together in one program office. Historical data sharing, and I do want to mention, despite what you might read in GAO reports and various other things, DoD does share a lot of information with VA, both one way when a service member is separating. We have 6.5 million, over 6.5 million records that are shared, that are for separating service members that are available to VA. And we have a bidirectional sharing where we share over 1.5 million data pieces every day between DoD and VA. So a lot of data sharing going on. We're taking that to another step here with moving from, yes, you have access to the information, but we want to use data standards, so you have standard data elements. We delivered the first set of those mapped standard data elements end of December. They went into production in our Joint Legacy Viewer, and then we're, both VA and DoD are delivering the rest of those mappings the end of September in compliance with the NDAA for 14. So lots of movement from being able to kind of do read-only data sharing to more of data mapping of two standards, so it's standards-based exchange with the delivery at the end of September. And one of the things Dave Parker talked about was being able to use the data. A lot of our focus has been on continuity of care, but there are many other use cases. One of the ones that kind of came to the forefront was with VBA and the backlog and that kind of thing. So VBA needs health records, Social Security Administration needs health records, so there's benefits adjudication use case. Within DoD, we also have several use cases related to being able to do force readiness So we want to know when you had your last physical, when you had the last dental exam, those kinds of things as part of readiness. We also have population health, particularly in theater. We want to know what the population health looks like in theater, and then as a whole, what all the beneficiaries' population health looks like. And then one of the things DoD and VA and others like Aetna have been focused on is sharing data with the patient themselves so they can be more empowered to participate in their own care. Blue Button was one of those things both DoD and VA really pushed for. I think VA's been a little more vocal about that being available, but it's also available in DoD, that information for download in various formats. And then there's in those various formats, most of our patients who come in and pull that information down pick PDF, but we also allow unstructured text, ASCII file. And the main reason for that is for value-added capabilities to pull different Blue Button information together and be able to provide patients with value-added type of information and to be able to act upon that information. That's kind of in its infancy. I think many of you might have recently seen a VA announcement about being able to kind of put it, have the app and be able to have it there. You can also pull down the DoD information and put on the app as well because they're using those standards. So lots of uses for that health data. We've really been focused on continuity of clinical care, but we have to think about what those other uses are moving forward as well. Thank you.
I have to use the mic. Okay, so in the spirit of the premise that I've listed for ourselves for this dialogue, engaging the audience in this collaborative discussion, first and foremost, and secondly, to help get industry focused, specifically in areas that can help these folks and the rest of the federal leadership in this domain area to be able to overcome some of the obstacles that they still face, to get beyond some of the challenges from interoperability, to use some of these terms, to operability, from exchange to use of that data. What is it that we can do? And I'd like to open up the floor to questions or comments or experiences that support that type of a dialogue. So any questions at this point? Because don't forget, I'm not supposed to ask my list. Okay, please.
Yvonne, I'm actually with the DHMS IPO office, and the question I have for you is, it sounds like the technology, and from my experience, the technology exists today. What we don't have is an informed workforce, necessarily, trained workforce in the new technologies. So how are you looking at, one, training the workforce, but also doing the change management aspects of the roles and responsibilities we have today?
On my, but I'll talk a little bit about change management because whenever you are changing your electronic health record, and really the EHR is a little bit of a misnomer because we use EHRs to kind of manage hospitals as well, right? So it's a major change. One of the things that we're doing is we actually have a functional champion organization that we've stood up and then we're kind of staffing now. And that functional champion is focused on business process standardization. Dave Bowen talked a little bit about, the different services doing business different ways. Well, we have one EHR, we're going to configure it one way. So that means there's a lot of work to do on business process standardization, clinical process standardization, even prior to having the new EHR implemented across the organization. And that's a role we assist, but the functional champion has lead on that. We've already done some. We have a group called the TRICARE, or the Tri-Service Workflow Standardization Group. And that group has already, on the inpatient side, done a lot of work on business process standardization and workflows, and we're going to have to continue to work that going forward, because we do have a commitment from the services. We're going to configure it one way across the enterprise, and that they will modify their workflows to meet that one way of doing business. And that's really a crucial thing, because you can't really improve across an enterprise unless you're doing things in the same or similar way, and then you only change the way you're doing it in a kind of a controlled manner. So we're going to try this, and then we're going to see how it goes. If everybody just does it differently, it's very hard to do any kind of improvement across a system. So that workflow standardization and business process improvement is kind of a critical part of this as well.
So I would look at that question in two different ways. One is, how do you change the model of delivery in healthcare? And what we do today is largely an artifact of reimbursement. Even in a system that's self-contained and largely globally paid for, like MHS or VA, because it's people's expectations. We make appointments, we see doctors and nurses in clinics, the doors are shut. And the challenge is making both the patients as well as the providers understand that there are new ways of delivering services, virtual care, telehealth, secure messaging, peer counseling. The best way to manage a chronic disease is probably not to talk to a doctor or a nurse, but to talk to another veteran with the same chronic disease. How do you reflect that in everything from coding, billing, workload capture, and the like? And how do you get providers comfortable for working in the kind of team environment where that it necessitates the doctor or the advanced practice nurse may be way up here supervising the work of lots of other agents that are much closer to the ground. The second piece is the data, and I think there's to move from our first generation of performance measures. We're doing good care because last quarter we hit targets for blood pressure control. That's getting to be rather passé, and it may in fact be getting dangerous because it may be inciting over-treatment, like the 75-year-old with limited life expectancy that someone feels we have to do a screening colonoscopy because they might die of colon cancer. That has to be something that's more tailored to the patient, and our data has to reflect it. And Terry and I and a few others have an article in Health Affairs back in, I think, April or May this year, which actually talks a little bit about that. How do you project forward information to be predictive? What are the skill sets that you hire? Bob McDonald, who's now our secretary, came to us from Procter & Gamble. One of the first things he did after we met him was to introduce us to his former CIO in P&G, Global Product CIO. They're an $80 billion business. They have 6,000 people in their analytics shop. I would venture that healthcare is a little more complex than Pantene or Tide, and we have nowhere near that numbers of analysts or even some of the expertise or platforms to run real-time simulation, to do predictive or Bayesian modeling, to take this information. And somebody came up to me and said, well, have you thought about Lean Six Sigma? And it's like, absolutely. How do you apply it in real time to process flow? And so those are things where you not only need to attract the skill sets, but you also have to change some of the cultural attributes of healthcare so we can practice in that manner.
I just add that in the private sector, and I think that you were just, again, making your nobody cares about infrastructure until the bridge falls down point, which, if you do nothing else coming out of this, then help message that problem and how important it is for our investment. We're never going to achieve the outcomes that we're trying to achieve if we don't actually put the resources into it to do it, and the IT is the least of it. So one of the most exciting things to come out of the ACA that in a lot of ways doesn't get that much press outside of sort of like a small area is the Innovation Center at the CMS. And they have a big program, about to announce a round of second grants. I do a lot of work with the states that have a state innovation model grants, and they're doing basically practice transformation on the ground and supporting that kind of transition from lone cowboy to team-based medicine. getting a lot of support from the ONC regional extension centers in that work that are now transitioning from just adoption to use and practice transformation. Because obviously, if you're not, if you just reproduce electronically your old paper-based system, then you're not really changing anything. So there are lots of good efforts and nowhere near enough resource to support all of them, if we're actually serious about what we're trying to do with this transformation.
Hi, Mike Farabakshian, Booz Allen. I have a 14-letter long last name, and I joke that if anyone spells it right in the first try, I'll give them $1. I usually don't do that. Other than Mr. Posnak's story about his children, and that's very near and dear to my heart and my name, what is the general strategy for data quality and, more importantly, remedial and corrective actions? With a lot of move towards big data, you're using non-relational models for storing information. With the heavy emphasis on data warehousing and data marts, again, a lot of things aren't normalized, and so as a result, there are plenty of opportunities for errors to remain in the system. Let's just say someone spelled a name wrong. Let's say a doctor decided to use free text. Let's say they couldn't agree on a taxonomy, and they said high blood pressure versus hypertension versus high BP, whatever. And then a correction has to be made. What is the overall approach for percolating an authoritative correction through such a massive enterprise system when everyone's connected and you need it on mobile? And speaking to Mr. Brown's points, how does that, the security implications of that, what's the strategy overall for corrections of human error in a system that's increasingly becoming unable to be managed by a single human or a single group of humans because it's so decentralized?
I think we have all those mechanisms internal to our own systems. But now that we're connecting system to system and sharing information that way, there really isn't methodology for correcting across systems. I mean, the best way to do it is go to whichever system the error occurred and then kind of follow that. But there really, I don't believe there's a way to kind of correct it globally across systems unless somebody knows of something. No, I don't think so. But that's a great question.
You know, ideally, it would be to reduce the number of times that data exists. How that is done with such a, such a wide scope of users and sources, that's going to be the challenge. Moving in the direction of big data and the ability to, create these, I said it earlier in the previous panel, these data lakes by which, data rests in one place where many people come to, and having some role-based access controls by which individuals of a certain role come to the same place for that data. That's ideally a solution, but even that creation is still something that's evolving. So as my panelists said, the mechanisms are in place, I believe. The processes are in place, but we're still figuring out how best to apply them.
So thank you all for your comments. I kind of gleaned from what I was hearing, especially Dave and Joe. And I have two fundamental questions or observations. One is something you talked about with outcomes. Who establishes the priorities for outcomes? There's a lot of outcomes we want to have, and not enough resource, not enough money, not enough time. I get all that. So establishing the priorities is one fundamental observation. The other one is echelon of need. So you've got emergency rooms, general practitioners, mental health providers, terminal health providers, all sorts of providers out there that have different echelons of need around data. And I would assume that would invoke different levels of standards and quality as well associated with that. So just as a data point, I was kind of wondering from the priority perspective and establishing of echelon need, how does that actually get done today?
I'm sure that all too frequently, I'm sure the answer to that question is the squeaky wheel. Because you're dealing with a governance question, which is kind of the perennial question and challenge in these areas. I'm probably not the right guy to answer the question, because priorities seem to come, what's the latest emergency of the week so often. I don't know. Probably a good Terry question.
Ultimately, the prioritization for outcomes should be driven by the patient or the patient spokesperson. That's not what we typically do in healthcare, and there are a variety of reasons for that, but including regulatory, it's what CMS is measuring. I argue with most people that mortality is, in most situations, a pretty meaningless measure of quality. I'm serious. It's one of the great case studies, one of the great mass murderers in history, Harold Shipman in the UK. It took 10 years of mortality tracking to detect the statistical signal that he was knocking off little old ladies. So if it takes us 10 years to find a determined murderer, how are we going to find realistically what's, might be deteriorating quality just by mortality tracking in a month or a quarter in a hospital? It doesn't work. But it's easy to measure, and it seems so obvious that you don't want to die in a hospital. But in fact, it happens every day, and it's expected. Now, the harder part is, okay, every patient's going to want a different outcome. How do you create a scaling for attaining a patient-specific goal? So you have methodologic problems here. You have the measurement problem. Do you really have time for every patient to complete that functional status questionnaire or that quality of life questionnaire? That's really hard to do. And how valid is that questionnaire going to be completed in a busy clinical setting where there might be all kinds of influences? We're struggling with this issue because the Institute of Medicine says, VA, shame on you because you're not collecting and tracking outcomes of PTSD patients. That's a real toughie because, how you feel may change from day to day. The stress of going through traffic to go to your appointment. There may be some secondary gain issues because your functional status may tie into our disability payment system. You may become lost to follow-up. So we're not able to do this longitudinal assessment of care. And so the things that we would really like to do are methodologically really, really hard to do. And create burdens on the providers and the patients. So, we need a lot of experimentation. We need PCORI. We need some of the fundamental basic science of measurement. I think we need more direct electronic monitoring so that we don't have to put this on the backs and shoulders of doctors and nurses. And so that to me is the issue. As for, echelons of need, I think in general, the more acute the problem, the more you need good information quickly. But I will tell you that in the trenches, a little bit of good information goes a long way. Knowing the drugs that people are on, knowing if they have advanced directives, being able to, what a blessing it is for a VA. One of the biggest risk factors for veteran suicide is taking too many narcotics, too many opiates. And sometimes they have legitimate needs, but a blessing we have now is we can look up what's happening in the DOD if they're going to see going to an MTF. We now have in many states, thanks to the interoperability work, the ability to look at state narcotic registries. It's an amazing boost for safety, even though we're not able to look at the entire electronic health record. And so those are the things that, over time, this is not a hit the ball out of the park business. This is small incremental gains.
for one. So both to that question and the previous question, I mean, I'm kind of a glass half full guy. I guess I wouldn't do the kind of stuff I do if I wasn't. But kind of going along with Terry's point about how you don't have to, there is redial on phones now, and we have come a long way. So one of the most significant things that's happened just since our new national coordinator has come into her position is a real commitment to looking at where we're going so that we can then begin planning backwards for what steps we need to take to get there so that we can sort of design with the end in mind. So the goal and the vision that ONC has put forward that isn't just for ONC but is for the whole country to move to a learning health system that has the kind of ultimately longitudinal information that Joe is talking about is now out there on the table as a flag planted, which really wasn't there. It was really our national policy was much more of a random walk. And so the work that is now underway for the interoperability roadmap to segment out in 3, 6, and 10-year goals, and hopefully like a bunch of the stuff that we're saying is 10 years is going to happen more quickly, because I think everything in IT does tend to happen a little more quickly. And more slowly. It's paradoxical. But there's a commitment at the federal level to actually making more sense of this and being more thoughtful. I think that to the outcomes question, absolutely lots of the outcomes determined by a bunch of different non-aligned programs inside CMS. That's something that my state colleagues complain about bitterly. And I think that HHS is beginning to respond, not as rapidly as many of us would like, but there is a real commitment across HHS, measure alignment, working with NQF and buying value for alignment at the state and private levels to bring these things together and to also use the technology so that we're asking providers to report once and have that data be reused many times. And you have to set out those goals to then design the systems to be able to achieve those outcomes. So I think there's a lot, now that we've got the base infrastructure in terms of the EHRs, we can begin to build on top of that. So it's it's a long, long haul, and it's made more difficult. Like these state innovation model grants, they're supposed to achieve a nearly impossible outcome of affecting 80% of the total population of the state through their experiments in 4 years. It's ridiculous. It's like a 10 to 15, it's a much longer, but that's another, looking for help from everybody on this topic, thinking about we need to be thinking more long-term about this. We need to be thinking beyond single, congresses, single administrations, single grant programs to a national commitment. How long did it take to get to the moon, right? These are big efforts. They're not going to happen magically without, sustained effort. But
ONC put that online, so it's available online. That's right.
Right. We're looking for comments, and there'll be first draft. First, actually, October 15th at the Policy and Standards Committee, sort of like version 0.5 something, and then it'll continue. But it's going to be a work in progress. I mean, it is the commitment is that it's not the Fed's roadmap; it's the nation's roadmap. Everybody should contribute to seeing yourselves and your families in that.
So just a really quick thought. Does everybody adopt the EHR as a baseline across the board? Do everybody feel like that is the baseline we're working on?
Where are you going to start?
I mean, just as a data standard, data quality, we're starting. I'm just curious if that's
So we kind of consider it the big elephant. It's kind of a
standard elephant.
Yeah, right.
Okay. Thank you all very much for the insights, for the opportunity to hear your experiences and your challenges and where you see this going, for engaging this community. And thank you all for taking the time to engage in the conversation. I think we're going to take a few minutes break, 2-minute, 3-minute break. And then we're going to come back and we're going to outbrief the aggregate conversations that have been recorded as we've been having these dialogues today. So thank you very much. Take a few minutes and then please come back in and join us as we sort of aggregate and outbrief. Thank you.